I'm Blum, and my group also studied abroad in India this last January, but we were looking at HIV patients who were visiting the treatment center at this campus. Before we start, I just want to do a brief overview of what HIV is for anyone who might not know, or if you just want a refresher. HIV, or human immunodeficiency virus, is a retrovirus that attacks the immune system, cells, specifically the CD4 cells, and this makes people a lot more prone to other diseases. And this is ultimately what people with this disease end up dying from, are these opportunistic infections. And when CD4 levels reach a level below 200, they're considered to have AIDS or acquired immune deficiency syndrome. And there's no cure for this disease, but there are treatments that can help to increase CD4 counts and prolong lifespan. And this picture, it may look a little strange, it's from a teaching manual that was at the clinic that we were at that was used to educate patients about the disease and their treatment. So this was mostly, a lot of these in this learning manual were pictures because many of their patients were illiterate. An overview of our study, this was conducted at the Antiretroviral Treatment Center at Ahmednagar Hospital. We wanted to just get an overview of the realities of living with and treating HIV in this area. So we looked at social medicine, including what the typical patient looked like, and asked interview questions about their perceptions of their treatment and how they thought the disease was affecting their lives. Pharmacological data included what treatments they were on and how this was affecting their CD4 levels. And then medical data included looking at alcohol and tobacco usage, hemoglobin levels, opportunistic infections, as well as HIV and tuberculosis co-infections. So the ART Center, where we conducted our research, just a brief overview of what they provide. They provide free HIV treatment and CD4 testing. The medication is provided in a month's supply, so they have to come back every month to get checked up and receive more medication. There's 2 counselors on staff that provide free counseling for all the patients there to help them in dealing with the disease and any difficulties they may be having. And there's also a VHAN program. So if patients are defaulting on their medications and not coming back, this center has individuals who are HIV positive who will go out into the community and find these defaulters and convince them to start taking their medications again and just tell them how important it is to continue taking it. This is just kind of a brief overview of the path that a patient would take when visiting the clinic. Something unique about this is that patients would never really go in these rooms. Most of the work was done by just putting their medical charts through those slots in the windows. Starting off with the conclusions that we got from this study, we got a lot of epidemiological data for an understudied population. So India has the highest population of HIV-infected individuals in Asia and is the 3rd highest in the world. And of those that are infected in India, 67% live in rural communities. So this is a fairly significant portion of the HIV-infected population worldwide. This also gave us proof that these HIV medications are effective at increasing CD4 levels, even though they're not first-line medications in developed countries like the United States. We also found a possible decrease in HIV and tuberculosis co-infection prevalence. We found a 12.8% prevalence, and a previous study conducted 5 years ago at the same ART clinic found a 17% prevalence. And the 4th conclusion that we came to is that we need to continue working to empower women throughout India. We saw a big trend we saw throughout the interviews was that women were treated much worse than men, and they still need to work to empower women and help them become equal. So how we conducted the study, our qualitative data was obtained through a 24-question interview through a translator who was a medical student at the school. Our quantitative data was obtained through the patient's physical medical charts, and total we had 200 medical charts, and 50 of these patients were also interviewed. For our socio-demographic results, our picture of kind of what the typical patient looked like, 32 years old, mostly female, secondary level of education, most were employed. The average household income was fairly low, though, which was around $38 per month. Most people were married, about 30% were widowed, and most of these were widowed due to a spouse passing away from complications due to HIV. And risk factors, 84%, this says heterosexual, and this was how it was denoted on the medical charts, but we were told by the counselor that if this was marked, it means that a male usually got this from a female sex worker and then passed it on to his wife. And then we also saw a fairly large portion of mother-to-child transmission, so we were able to interview a lot of children with the disease as well. As far as pharmacological results, there were 2 main treatment regimens that we saw people on, were ZLN and TLE. So this was 3 different medications in a fixed dosage in 1 pill. and this is usually used in developing countries to help increase adherence. We looked at CD4 counts at the initial, and then 6 months, 12, 24, 36, and 48, and we also looked at weight. This did not have any trends throughout their treatment, and also we asked the patients about their perceptions of the medication, and most just mentioned side effects initially being nausea, vomiting, and hyperacidity, but most mentioned that they went away fairly quickly. And this is another picture from that learning manual that I mentioned earlier, just educating patients about their medications and why it's so important. So this just shows the effect of the effect of the different treatments on CD4 levels throughout their treatment. There were no significant differences between the two, and that slight decrease in month 48 for the ZLN treatment was just due to a low data, or not enough data for that time. Our medical results, we found that tobacco use was twice as common as alcohol usage, which is much different than it would be here, but alcohol was not very common in that area. Hemoglobin levels, ZLN did show a bigger increase in hemoglobin levels, which is an indicator of anemia, but it was not significant. And as I stated earlier, the tuberculosis co-infection rate was 12%, which was down from the previous study that had it at 17%. In opportunistic infections, we found that those on the ZLN treatment were significantly more likely to have gotten an opportunistic infection, which was not something that we were expecting. From our interview trends, one of the big trends we saw was that men were often treated better than women. So when a man had the disease, the wife would often stay with him and she would take care of him and keep the kids. But when a woman was positive, the husband would often leave, take the kids if they were negative, and the woman would often be shunned by the in-laws and sometimes kicked out. Another big trend we saw was men beating their wives. This usually happened when a man was infected with HIV from a sex worker, and he would beat his wife to tell people that they both got HIV from a doctor that had gone wrong with an infected needle. And the counselor said that this was actually a fairly common thing, and he usually got the women to tell him this during about the 5th counseling session. They would confide this in him, which was very significant. And then finally, another big trend we saw throughout this was the stigma surrounding the disease. There were a lot of misconceptions, a lot of people saying that it was a curse, and a lot of misconceptions about the way it spread, with some people thinking that it could just be spread through normal touch or mosquitoes. And in response to this, as a lot of individuals we interviewed were younger, they have created marriage institutions in the area for people that are only HIV positive so they can marry within their community and not worry about infecting anyone else. Limitations in our study, there were inconsistencies in the charts versus what the patients told us. A lot of information in the charts hadn't been updated, or some of it was inaccurate, so this was probably also true for the 150 charts that we looked at that we did not interview. There's also the possibility of patients not telling the truth, since we were outsiders in their community. There's also inconsistent record keeping, as there was a high turnover rate of employees at the ART center, and we also had a fairly small sample size. That's it.